So the next part of the program is one that we love because it allows us to kind of bounce questions off the audience and for you to bounce questions off a panel of experts. And we have a great group of faculty members for this cases discussion. And it will be chaired by Raj Gandhi. Raj is at Harvard, at Mass General Hospital, where he's a professor of medicine. And sort of by the way, and not by the way, Raj chaired the IAS-USA HIV treatment guidelines that were published just recently in JAMA. So Raj is ideally able to take us through this. Raj, and you'll introduce the panel.
I will do that. Thank you very much. It's really a pleasure to be here and to see you all. We're going to go through a number of challenging cases in HIV. I'm really thrilled to have a distinguished panel here with me today. I'm going to introduce them starting on your left with Dr. Levison, who's at the Baylor College of Medicine, Dr. Carlos Del Rio at Emory University, Dr. Connie Benson at University of California, San Diego, Dr. Mike Sag at University of Alabama, Birmingham, and last but certainly not least, Dr. Judy Currier, who you've met before from UCLA. So we're going to go through at a fairly reasonable pace a number of cases. Here are my financial relationships, and here are some of the learning objectives, although there'll be a number of cases that will go even beyond these particular learning objectives. We're going to try to do about 7 cases if we get to them, and a bonus case if there's time. But we're going to start, though, with a very special case. And this is a case, and I'm just going to make sure that all are looking at this case. A distinguished man sees you in clinic with the following history. This man grew up in Rochester, Minnesota. His bedroom window oversaw the Mayo Clinic. He received his MD from the University of Minnesota and did medical residency at the University of Utah, so you will be asking him some questions about skiing. He trained in medical oncology at UCSF at the dawn of the HIV epidemic and conducted groundbreaking work on Kaposi sarcoma and other complications of AIDS. He was a pioneer in establishing the collaborative team-based approach to HIV care, and he has too numerous to count leadership positions, including the head of the Center for AIDS Research, Chief of Medical Service at the San Francisco VA Medical Center, Director of the UCSF AIDS Research Institute, and a founding board chair of IAS-USA. So for our panel, what is the differential diagnosis and what is your evaluation? And so I will start with Dr. Currier.
Oh, I get to go first. Wow, what a pleasure. So I also grew up in Rochester, Minnesota. Fun fact, and throughout my career, I've had the really great honor of knowing Dr. Bolberding and having him as a mentor and a friend and a brother. As I started to get involved in HIV, my mother would say, "Do you know that Dr. Bolberding? I was reading about him in the paper, and you know his farm is right up there. Their barn is over there." Anyway, I finally got to meet the famous Dr. Bolberding, and he's been really a tremendous role model and inspiration for me throughout my career. And we're so lucky to have his wisdom in the IAS-USA, and it's also really looking forward to see what he's going to do next in the next chapter. So just congratulations, Paul, on all of your success, and thank you for all you've done for this organization and for all of us.
Dr. Sag.
So I've one quick thing to say, and then one quick story. The quick thing to say is that UCSF, under Paul's leadership, developed the first HIV dedicated outpatient clinic in the world. When I was a fellow, I went and spent a day there, and our 1917 clinic in Birmingham is based on a model of their clinic, but basically I went around and asked one question: if you were starting over, how would you design your clinic? And just took their best practices and tried to implement it. The story I'll tell, I think, says everything about Paul. That when I was a fellow before that trip, the International AIDS meeting was in Stockholm, and we're flying through Frankfurt, Germany, and I get off the plane, and Paul and Merle Sandy had just published a Saunders update on HIV, and I had it in my briefcase, and then I look across the way and I see this guy. I said, "I think that's Paul Bolberding." So I walked over and he signed the book, but more importantly, when we got off the plane in Stockholm, I was by myself. I didn't have anything. And he waited for me and took me in the car that came to pick him up and took me into downtown Stockholm. So I thought that just speaks volumes of the type of person that Paul is in everything that he does.
So I don't know exactly how to describe the differential diagnosis, but I think we're getting there.
And one of a kind.
One of a kind. There's only one thing in the differential diagnosis, right? But I first met Paul at an interesting meeting that was, a lot of us have in common. It was in San Francisco, and it was the first, I got invited to go by, just after I finished my fellowship, by Harold Kessler, who was an early member of the board of directors for IAS-USA, because Harold couldn't go. And I was supposed to do his talk, and Paul was doing, it was a symposium very similar to this, but being run by Howard Reese and the World Health Communications Group, which I think was one of the ones that Paul decided we needed to do something more independent of that, which led to the establishment of IAS-USA. So it was a long time ago in the early days of HIV. Paul was also the chair of ACTG 019, and I worked closely with him and several of the other protocol chairs and investigators on that study in the early days of the AIDS Clinical Trials Group Network. And Paul's commitment to the disease, his commitment to science, his commitment to fairness and sanity in doing clinical trials has not changed in all that period of time. So I think his contributions are too numerous to count, and that's my evaluation. But all I can say is that I've valued Paul as a colleague, a friend, a collaborator for many, many years now. And while I think it's important for people to move on to new stages in their life and new horizons and challenges and things to do with their careers, we will miss him terribly being part of courses like this and being part of the leadership of the IAS-USA. So just thank you, Paul, for all of your contributions and all of your friendship and leadership over the years.
So one thing that I think Paul taught us early in the early years of the HIV epidemic, when many in the infectious community really had little interest in this disease. Paul, a trained oncologist, because of the connection with CAPSIs, but he could have said, I'm just going to deal with the cancer part. But he really understood what was behind and what needed to be done for this disease, which was an infectious disease. And he became one of the leaders in HIV without being trained in infectious disease. And that, I think, opened the door for many other specialties to do that. And there are many people like Melanie Thompson, who's an internist, and other people who became family practice medicine, and other people who became experts in HIV. And I'll tell you, even today, I think, there are many of my ID colleagues that I will not let them close to an HIV patient, and because they simply have no interest or no training or no understanding of this. Paul was always in the forefront and always thinking ahead, and I think he reminds me of that, famous Wayne Gretzky anecdote. It's not where the puck is. He goes where the puck is going to be. He goes where the future is going to be. And in fact, so when I think about, a man from Minnesota and and his life and what he's done, you were saying skiing, but I'm thinking more hockey player here. And I think that would be I think that's what I would be thinking, that he's a tremendous hockey player. My personal knowledge of Paul goes back many, many years. Both Paul and his wife, Molly, have been fantastic friends, mentors, colleagues. And many years ago, when I was thinking about writing 1998, a grant for a Center for AIDS Research at Emory, and had no idea what to do, I said, I'm going to call the best CFAR I know, and the best CFAR I know was San Francisco. And Paul was incredibly grateful with his time, let me use his application to read over it and to see what they were doing. And really, it was thanks to that, sort of one-on-one mentoring that I was able to put an application together that was successful. So I have a lot of respect for Paul as a scientist, as but I have even more respect for him as a human being and as a friend. So good luck in your next phase of your career, Paul, but I think it's going to be hockey.
And I'm a relatively new participant in IAS-USA, but Dr. Volberding's name has been just intertwined in so many things that I'd read along the way, heard along the way. And last night as I walked into dinner, a man I hadn't met before came up to me and said, "Hi, I'm Paul." And I think that seems to say a lot about who he is, and just watching him in action in the last 18 hours, yeah, seems like a really great guy.
Terrific. I know that, I don't know if Donna or Hyman wants to say something, Dr. Scott or Donna, and then we'll go on to our other cases after this inaugural one. Dr. Scott?
Very good. And I've known Paul since I was a resident. Where's Paul? Since I was a resident at the VA. And I think selfless really comes to mind as a resident. I remember he was my attending, and we had an issue with PT that we raised in one of the meetings, and then I came back and talked to him later, and he'd actually gone down to the PT wing and tried to talk to the physical therapist without success, and had some very choice words, which are the same words I would have used. And so, he's been a selfless mentor. He's one of the reasons I stayed in San Francisco. He's been tremendously giving in his time and his energy, his guidance, and tremendous and open opportunities for early stage investigators, young early career clinicians. And so I couldn't speak more highly of Paul as a person, as a mentor, and as a scientist.
Hi, everyone. I'm Donna Jacobson, Executive Director of the IAS-USA and long-term friend of Paul Volberding. And this is going to be tough. I'll be short because I have the last word. Paul and I have known each other for about 37 years now, I think. And he came up with the idea of doing something important and special with the IAS-USA at that time. And for these 37 years, he's been my friend, my mentor, and my guide star in this organization. And I'm not going to miss you because you're not going anywhere far away. But in preparing for this sort of celebration of Paul, we asked 200 or 300 of his closest friends to tell us, what do you think of when you think of Paul Volberding in our word cloud? And so actually, unfortunately, he was copied on the email asking for the word cloud. So the first words, he was the first one to respond, and he said tall, dark, and handsome. But as the words started to come in from these hundreds of people, the first few really stood out as the most often referred to words about Paul, and I think this really captures it. Kind, innovative, look at IAS-USA 31 years later, leader, smart, and thoughtful. Those were the first that were coming in, and then as the hundreds of words continued to pour in, Paul, this is what your colleagues think of you as a human being. The larger the word, the more times it came up among all these words. And you see that leader, visionary, kind, thoughtful, committed are the words that really to other people represent you. And I think this is so true. There are a lot of words that came out, in the smaller type because they came one or two times. Well tanned, something that came up. But I can't thank you enough for everything that you've done in this whole field, but also, and mostly from my perspective, what you've done to guide this organization for these many years, and all the wonderful work we do, and all the tremendous volunteer hours that you've put into it, along with the rest of our board, into making this organization work. So I love you, and I thank you.
I'll just say that the word evaluation has value in it, and I think, Paul, you brought a lot of value to all of us, and we value you so much. And the word that I would put up there, I did send in my words, but I would say courageous. For those who have seen this video that was at IDSA, ID Week some years ago about, I think it had the word lifeboat in it, and it talks about, Paul presented that, but go back and watch that. That's a really demonstration of his courage. So let's go ahead and get started, and with gratitude, Paul. So we're going to highlight a number of cases, and the first case that I want to highlight is a case related to HIV and pregnancy. So this is a 35-year-old woman with HIV. She's receiving bictegravir FTC TAF. She's virologically suppressed. Her CD4 count is 500. On a routine visit, she mentions that she's missed her last menstrual period. Her pregnancy test is positive, and she's at the end of her first trimester. So we're going to give your cell phones a workout here, and let's see. Do you recommend a change in ART? Go ahead and vote. Yes, no, or it depends. If you vote it depends, you'll have to tell us what it depends on. But go ahead and vote. What I'm going to do is I'm going to see what the audience thinks. I'm going to put up one other question, and then I'm going to get my panel's comments on both of the two questions. So one is, do you recommend a change in ART? I see that 30-something have voted. Let's get a few more. This is where Mike Sag usually calls the song, names that tune. Let's see what you all think. So it looks like about 2/3 would like to stay the course. A quarter would like to change. Okay, I'm going to put one more question, and then we're going to see what our panel thinks. So now this person is at the end of her pregnancy. She's remained virologically suppressed on the same regimen. She did stay on that regimen. And she's now at the end of her third trimester. And now the question is, she expresses a strong desire to breastfeed her infant. What do you counsel her? So let's go ahead and vote. You can start voting now if you'd like. A, the risk of HIV transmission if she's virologically suppressed is about 5%. B, the risk of HIV transmission if she's virologically suppressed is very low, less than 1%, but not 0. C, she should formula feed instead. Let's see what your thoughts are. And I will say, some of what this case, and people are voting, I see it looks like 50-something have voted. This was not as much of a focus at CROI, but there was a very special session devoted to some recent ART guidelines. Dr. Levison is on that panel, and that was a particular highlight for me, of course. So let's see what people think. Let's see, can someone advance? Oops, there we go. Okay, so most of you, that's nice, it shuffled it, so it's 77% think that the risk is very low, a few percent say that the risk is 5%, and about 20% say formula feed. So this one I want to go in reverse order. Why don't we ask Dr. Levison, who's one of the authors of the guidelines, if she will comment on the infant feeding question, and then we'll see our panel's thoughts on ARVs. So Dr. Levison.
I'm actually going to answer that during my talk.
Okay.
Which is immediately following this.
Yes.
But if you want me to give an answer, I will.
I'd like you to give the top line and then go into detail during your talk.
Okay. Yes, I agree with the majority, and I'll give you some of the details during the talk. And the big change in the guidelines is a shared decision-making perspective, which is rather than you should formula feed.
Great. So it sounds like we're going to hear more. What about ART? If I could ask one of the other panel members, this person's on bictegravir FTC TAF. What would you do with that, Dr. Perrier?
Thanks. Well, first of all, I think one key thing that this case brings up is preconception counseling, which is really important if you have women in your practice who are considering to discuss, are considering having children, and to talk about these things ahead of time, so that you're not finding yourself with the person who's pregnant then having to decide whether to change. I would probably leave her on this treatment because it's working. It's one of the treatments that we don't have as much information about, and so that's always a question about whether to switch to something that we know more about, like dolutegravir, which, and I don't know her history, but which is considered safe in pregnancy, or to continue on what she's on. And I think preconception counseling would also allow you to start discussions about her infant feeding issues earlier, so that you're not at the third trimester dealing with it. So a plug for preconception counseling, and I'd continue the treatment she's on.
Terrific.
Raj, the only thing I would add is that you know, if she wasn't, when Judy talked about preconception counseling, I was thinking about a woman who's not HIV, who's HIV negative, but who is at risk of HIV, and there was recently a study published looking at can you give them PrEP, and is there an impact of adverse outcomes of pregnancy or in the baby of doing that, and the answer is basically no. So again, we need to think in that preconception counseling of women at risk of HIV that we don't want them to get HIV during pregnancy, which is a period of high risk of acquiring HIV infection.
Terrific. I think we might hear more about that from Dr. Scott. He's going to be talking about PrEP, but definitely stay tuned, and that's an important message for sure. So I wanted to bring this case for a couple of reasons. One is to get the pulse of where people are at with this, but also to highlight some of the recent changes in the guidelines. So the DHHS guidelines in the late January put out some new recommendations, and I wanted to make a few points here. They now put dolutegravir as the preferred integrase inhibitor, and that's based on reassuring data from SAPAMO and other studies on the lack of an effect on neural tube defects, or a protease inhibitor, ritonavir-boosted darunavir, and I stress the word ritonavir-boosted darunavir, with 2 nucleosides, so still 3-drug therapy for women for people during pregnancy, and the nucleosides are listed there.
And
What
Raj,
they say,
I just want to make a point related to that. It's the what to start in pregnancy. This is for naive
correct,
patients.
yes.
And I really want to emphasize that
Yep.
because the category of what you come in on, if you come in on something, we generally say, please stay on, because changing often disrupts viral suppression.
And that's a very good point. This is when people are initiating therapy. I'm going to mention some of the major changes in just a moment. Dr. Currier already mentioned insufficient data currently for bictegravir and viduravir. The ones that they're clearest on not recommending, or they're recommending against, are all of the cobicistat boosted regimens based on PK concerns. Right now, initiating long-acting cabotegravir rilpivirine is not recommended, and the initiating 2-drug therapies, the ones listed here, is also not recommended. The IAS-USA put out their guidelines, which are largely concordant, but the IAS-USA in December 2022 highlighted dolutegravir plus TAF-FTC as a preferred regimen in people initiating therapy, and that's largely based on a very important, I would say, transformative study called IMPACT 2010. The main results of IMPACT 2010, this was a study done in women mostly in Africa, who were in their 2nd and 3rd trimester, and these individuals were randomized to either get dolutegravir FTC TAF, dolutegravir FTC TDF, or what we used to use in the past, efavirenz FTC TDF. And essentially, adverse pregnancy outcomes were lowest in the individuals who received dolutegravir plus FTC TAF. And if you look at infant outcomes, what you're seeing in the graphic is rates of infant stunting. The dolutegravir regimens did better than the efavirenz regimens. So this has led to a couple of major changes in the DHHS guidelines that have now put raltegravir and boosted atazanavir as alternatives to the preferred. And as Dr. Levison was just saying, if a person is on a regimen with insufficient data, you have 2 options, really. One is to continue the regimen, but do frequent viral load monitoring, or have a discussion around some of the recommended regimens. What I won't go through is the infant feeding changes. You're going to hear more about that, but this is really an important, I would say, advance in terms of counseling. That formula eliminates HIV transmission. Viral suppression on ART decreases suppression to less than 1%, but not 0, as I think most of you said. And that individuals who choose to breastfeed or formula feed, either one should be supported in their decision if they're virologically suppressed. The last point, which I'm sure Dr. Levison will stress, is there have been instances where Child Protective Services have been engaged, and this is completely inappropriate, and I'm sure she's going to talk about that. Okay, let's go on to case number 2. So now we're going to go over to a 45-year-old man who has a family history of CAD. He's got a history of he was diagnosed with HIV about 19 years ago in 2004. Between 2004 and 2009, he was essentially an elite controller. His viral load was over 1,000. His viral load was less than 50. His CD4 count was over 1,000. Now, starting in 2009, he developed some intermittent bouts of viremia, viral loads that fluctuated between 50 to 200. And in 2019, when I was seeing him, his viral load was 150, his CD4 count was 510, and his CD4 to CD8 ratio was 0.8. So let's see what you all think in terms of, would you recommend to this person, you're seeing him now with the numbers there, Would you recommend that he start ART? Yes. Recommend that he not start ART? No. And let's go ahead and start the polling, if you would. C, only if the CD4 count declines to below 200, it's 510 when you see him, or his viral load is above 200, or you're not sure. So let's see what you all think. So obviously, over the years, we've gone to a treat-all approach for most instances, but this is, I think, the one instance where people still have discussions around whether we should be treating HIV controllers or elite controllers. So I'm interested in what people would do. So let me, okay, so almost 90% of you would say yes. Let's see what our panel thinks. Dr. Sack.
I agree with the audience. There's a lot of subtlety here, but first off, it's hard to call somebody an elite controller if their virus becomes detectable above 50. So that's point one. But I think what we tend to overlook is that how is the viral load being suppressed? And the answer is it's the immune system managing it. And that takes energy and effort over time. And what we don't know but are concerned about is how much does that inflammation associated with the control of the viremia ultimately lead down the road to more of the complications that we'll talk about a lot, we'll hear about later today, from antiretroviral, from HIV itself, even when people are on antiretroviral therapy. So all things being equal, I would lean towards starting therapy. I wouldn't bang my fist on the table or turn them over to Child Protective Services, but I think the point is that it really would be strongly encouraged to stop that de novo replication. An important point of the case is that the CD4-CD8 ratio is 0.8. That's not terribly bad. When it gets below 0.5, I think there's a lot of evidence that there's complications. But at 0.8, it's kind of in a gray zone. But just putting it together biologically, I would treat.
Any dissenting opinions?
No, I don't think it's a dissenting opinion. I mean, I agree with Mike, but I think the point I'll make is that there's no randomized trial in telling us what to do, and the reason is, you know, ACTG tried to do a randomized trial, and at least my experience in people who we thought could be enrolled in the study down in Atlanta, who we got referred, when they went back to talk to their physicians said, oh, no, you don't need to be treated. So, you know, we sort of prevented ourselves from doing what we needed to do, which was really have better evidence of this. Having said that, when I meet with people like this, this individual, first of all, I agree that I'm not sure I would call this person a total elite controller. He's a slow controller, a slow progressor, or whatever, but I tend to tell them that what I would do if I was in that situation, what I would do in that situation based on the available drugs that we have today, which are well tolerated, I would take therapy.
I will say the START study looked at, the START study was a study that showed that we should be treating regardless of CD4 count. They did an analysis of people whose CD4 count was less than 3,000, not elite controllers, but controllers, let's say. And they couldn't demonstrate a clinical benefit because the event rate was low, but I would also treat based on theoretic reasons, and I'm going to show you some of the what I would call benefits of, theoretic benefits of treatment. So I would agree with you all. And I want to start by emphasizing that people like this, their immune system is working overtime essentially to control the virus, as Dr. Sag said. I'm just going to make 2 points here. People who are controllers have higher T cell activation than people who are on ART, so I think that's one very important point. And as you're going to hear from Dr. Grinspoon, there is a clear link between inflammation and coronary plaque, coronary artery disease. And there is evidence that elite controllers have more coronary plaque than people with HIV who are on ART or people who are without HIV. The study that the ACTG did do on treating controllers, not elite controllers only, but controllers, people whose viral load was less than 1,000, is shown here. 35 such individuals, of whom about a third were consistently less than 50 elite controllers. I will parenthetically say that Steve Deeks from San Francisco says it's an East Coast thing to call these people elite because he's so anti-elitist that he calls them, you know, it's an East Coast thing. But HIV controllers were treated with rilpivirine, FTC, TDF Viral loads, if you look with research assays at elite controllers, many of them have low-level viremia below 50 copies, and the viral loads went down. The residual viremia went down when you started ART, not surprisingly. But I think more importantly, the CD8 T cell activation went down, and there was decreased markers of immune activation. So I would agree with what the panel says. The DHHS guidelines largely say if you have a newly diagnosed person, don't wait to see if they become an elite controller. That's a strong recommendation. Start them during their acute HIV. Start them, of course, if they have progression of their CD4 count. Some individuals will lose control over time, or they'll have the dwindles on their CD4 cells, and they comment on the theoretic rationale. My own approach is to essentially look at their CD4 count, look at their CD8 count. If they have a decreased ratio, I would say they're probably more active as an elite controller. If they have an elevated CRP, if they have intermittently elevated viral loads like this patient did, then I would certainly treat those people, citing a theoretic rationale. One thing that is not controversial at all, though, is to monitor them if they don't go on therapy. Joe Aaron tells the story of a person who was an elite controller for many years, stopped engaging with clinical care, and eventually developed pneumocystis and actually died because of the loss of elite control. So people can progress, and monitoring is really key. I'm just looking around to see if there's any comments from the audience, or Dr. Benson?
So I agree with what everyone else has said, but I would take that a little further. I work in San Diego, where the HIV Neurobehavioral Research Program is housed, and they have data on elite controllers doing serial neurologic testing over time in people who are treated and untreated. And you can show very clear association with these inflammatory markers and neurologic abnormalities in neurologic function that are subtle but continue to accrue over time in elite controllers. And sometimes I worry more about the neurologic complications even than the cardiovascular ones. Obviously, we have some things we can do to prevent cardiovascular disease, but once you start down that pathway of neurologic deterioration, it's very hard to intervene and turn the car around. So I worry a little bit more about that.
That's a good point. Great, thank you. Okay, so we're going to shift gears again, and now we're going to talk about drug-resistant HIV. So this is and I will say as we start this case, I think in the last 5 years there's really been a revolution in our understanding of drug resistance, and we'll try to illustrate that. So this is a 50-year-old man with HIV. He's been treated with a variety of regimens in the 1990s. When you see him, he has resistance to the nucleosides. He has two nucleoside RT inhibitor mutations, M41L and M184V, the latter being quite common. And he has resistance to the NNRTI, the famous K103N. He's been suppressed for years on a combination of TAF-FTC, elvitegravir-Cobi, that's one pill, and darunavir. But you would like to change that medication because of drug interactions. And so what regimen would you choose in this person who has some nucleoside resistance and NNRTI resistance, with the NNRTI resistance being to efavirenz? So would you feel comfortable putting him on TAF-FTC bictegravir? Would you recommend that he go on TDF-FTC boosted darunavir? Would you avoid the nucleosides altogether and do the regimen that we heard about just a little bit ago, boosted darunavir plus dolutegravir? Or do you think that he needs a multi-class regimen with TAF-FTC, rilpivirine, and NNRTI, and dolutegravir? Let's see what you all think. No Broadway tunes. Mike. Okay, so good. It looks like a bit of a mix, which is good. About 2/3 like the TAF-FTC bictegravir. Some of you, though, would go for the avoiding nucleoside sparing regimen. And let's see what our panel thinks. Dr. Curry.
Yeah, this is a really great case. I think if you look back, when this person was put on it's a boosted integrase inhibitor and darunavir or something, back at that time, that was pretty common to do when people had NRTI and NRTI resistance. We were very worried about the vulnerability of integrase inhibitors and felt like it wasn't going to be enough, and for many people it was going to be like their next big chance, and we didn't want to screw it up. So we kind of did the belt and suspenders approach, and I think that a series of studies over the last few years have really demonstrated that you can have M184V and still not take out your bictegravir TAF or dolutegravir TAF FTC combination. So I think the audience is in sync with that without thinking, but it definitely was a moment in time where I think those of us who've been doing this for longer had a harder time of saying that's going to be okay, but I think we have evidence now that it's going to be okay.
Yes, my own practice has evolved in those last 5 years. Any other comments? 'Cause I'll walk through some of the things that got me to where you all are, which is with that point. Dr. Benson.
This might be somebody to consider lenacapavir now. And after what I just talked about, I think the data have been pretty impressive. And I think your choices B, C, and D don't really absolve you of drug interaction issues, whereas A does. And if you can get away with doing that with monitoring, that would be the simplest regimen to use. And I'd be happy doing that. But he might be somebody I'd consider switching to lenacapavir.
Lenacapavir with some other drugs, yeah. Let's walk through a kind of almost stepwise how we got to where we are. So what are the options for people who have drug resistance? And I'll start with just M184V. These are the data that now support that you can keep someone suppressed with M184V if you switch to bictegravir FTC TAF, but it's not unique to bictegravir FTC TAF. I think we would get the exact same results with dolutegravir FTC TAF. So this was pooled trial data from the manufacturer of bictegravir FTC TAF and looked at people who were virologically suppressed, and they were then switched to bictegravir FTC TAF. So they were virologically suppressed on some other regimen. There was 1,800 or so people. About 10% of them, about 180 of them, had M184V. They could either find it on a proviral genotype or they had a historic M184V. And what you're seeing in all those bars, which are all essentially the same, is about 95, 98, 99% suppression, whether people did or did not have M184V. So essentially, that's good data. These are good data. And again, I would apply this also to dolutegravir FTC TAF or TDF FTC. So let's go one more up. Now we're going to look at people who are suppressed on protease inhibitors. This is a study done in Africa. All these people were suppressed. People in sub-Saharan Africa get on a protease inhibitor if they've failed and if they've had virologic failure on an NRTI. So these people all had virologic suppression on a boosted PI plus 2 nucleosides, and they were randomized to either continue their boosted PI and 2 nucleosides or to switch to an integrase inhibitor plus 2 nucleosides. The integrase inhibitor was dolutegravir. Now, prior drug resistance was not assessed in this study. This study is called 2SD, but one would imagine that there would be a substantial resistance because by the time you have an NRTI virologic failure in sub-Saharan Africa, there's often a fair amount of nucleoside resistance. And what you're seeing in those two bars are high rates of virologic suppression, whether you continue the boosted PI or whether you switch to dolutegravir plus 2 nucleosides. And there was no resistance that emerged, and that's really important. The next two studies, one is one study that you've just heard of, one is a study that really laid, I think, the groundwork, is now taking people who are not virologically suppressed. The prior two studies suppressed, now they're not virologically suppressed. They're failing an NNRTI, this is a study called Nadia, and they're randomized to get boosted darunavir plus tenofovir 3TC, or to get dolutegravir plus tenofovir 3TC. There's also an arm that gets AZT, and I'm going to put that aside because the AZT arm did worse than the group that got tenofovir. Here they had resistance data, and there is a lot of resistance in Nadia. 50% of people had K65R, the mutation that knocks out tenofovir, and more than 85% had M184V. What you're seeing in those bars is that there's high rates of virologic suppression with either dolutegravir plus 2 nucleosides, or with boosted darunavir plus 2 nucleosides. So again, about 90%. And this is even the case when there was a lot of nucleoside resistance. So again, if you've got a high barrier to resistance drug with tenofovir 3TC, you're having high rates of suppression. Now, I will put one caveat here. In the people who got boosted darunavir plus tenofovir 3TC, there was no resistance that developed. About 4% of people who got dolutegravir plus 2 nucleosides plus tenofovir 3TC or AZT3TC did develop resistance, and I'll come back to that when I draw some lessons. I'm not going to go through this next study because Dr. Courier went through this, but this largely supports, in my mind, the data that we saw from Nadia, similar patient population, that is NNRTI virologic failure. In this particular study, though, it extends that to say that boosted darunavir plus dolutegravir, a nucleoside-sparing regimen, had high rates of suppression, and Dr. Courier went over that as well. So here's what I take from all of these recent trials. If you have a patient who's treatment experienced, who's virologically suppressed, like my patient, you can switch from a boosted PI to dolutegravir or another high barrier to resistance integrase inhibitor, even when you don't have full results of resistance testing. And that was certainly true in the 2SD study in Africa, and even where we work, we sometimes don't have all the resistance data. Second, in people who are virologically suppressed and whose virus is sensitive to an integrase inhibitor and a PI, it is reasonable to consider switching to tenofovir in either FTC or 3TC, plus either dolutegravir, bictegravir, or boosted darunavir. These are drugs that it's hard for the virus to get resistant to. That is likely to maintain suppression even if you have pre-existing nucleoside resistance like my patient did. And then last, this is the kind of the hardest. Now you've got someone with viral failure. They've got viremia. They've got nucleoside resistance. Your options, I think, include a boosted darunavir regimen plus 2 nucleosides, the Nadia regimen, dolutegravir plus boosted darunavir. Again, if you're trying to avoid drug interactions, then that would be not as good. Or dolutegravir plus 2 nucleosides, although there is a small risk of dolutegravir resistance. Many people will extend this also to include bictegravir FTC TAF, but we have less data on that. So I'm going to pause just for a moment, see if anyone wants to comment.
So the only thing on the last bullet, I go back to what Dr. Benson said about lenacapavir, right, being an option. The question I would ask you and ask others in the panel, go back to the first one about switching. How would you feel about switching that person to long-acting cabotegravir rilpivirine?
So that's a good question. So the question that is being asked is, this person with K103N, would you feel comfortable switching to cabotegravir rilpivirine? So the studies that got that regimen approved are studies done in people who did not have known NNRTI resistance. K103N in and of itself should not impact rilpivirine, but I do worry a little bit myself that if I have a person who has NNRTI resistance, that if there's some background resistance in addition to K103N, that cabotegravir rilpivirine may not be enough. And so I would either, it depends on the person. If that makes and breaks their ability to take ART, then I might do a proviral genotype. They've not been validated in this setting, but I'd be looking for resistance. But let me see what others think.
I agree with you. I think your point's well taken, that there is not that much cross-resistance, but you've got other options, and I'd feel better doing that.
Yeah, it's the company you keep with the K103N, and I think sometimes in people like this, the records that we have about their prior history and when they developed resistance and the data would make me nervous. So.
Great. Okay. So the next case is something that I think happens a lot, and so I wanted to bring it up as a point for discussion. So this is a person in his 60s who's got a CD4 count that was very, very low in the past, CD4 nadir of 50, also treated with a variety of regimens in the 90s. No known drug resistance, unlike the other patient. He's now on dolutegravir FTC TAF, and his viral loads just kind of fluctuate. They're never consistently below 20, but they're usually between 55 to 250, and he reports 100% adherence. So, how many of you have a patient like this in your practice? So yeah, pretty much everyone, anyone who's, okay, so what do you recommend, and I'm interested to see what you will recommend. Do you change his regimen to a boosted PI containing regimen, TAF, FTC, darunavir, cobicistat? Do you change his regimen to cabotegravir, rilpivirine? Do you add a drug? Do you intensify? Do you add doravirine? Do you figure out a way to check drug levels? Do you leave him alone, or do you do something else? So let's see what you all think. And I think we're all taking notes to see what you all are doing, because I would say this is one of the more common clinical questions.
I think GPT has created the music selection.
Oh, okay. I thought you would say ask ChatGPT for what to do for this case, but all right, let's see. No changes. Okay, about 56% say no change. That's the most popular, but then there's a variety of approaches, and I guess what this illustrates is there's not a simple answer to this. Some people would change, some people would add, and so let's see what our panel would do.
Well, to quote Gabby Johnson in Blazing Saddles, harumph, that I wouldn't change the regimen. If you go back, this guy's got a CD4 count at the beginning of 50. That means his viral load was probably in the hundreds of thousands at pre-therapy, and he's been suppressed. What you can translate that into is that he, relatively speaking, has a large reservoir of latently infected cells that every now and then are going to spit out virus. And that virus can be detected. It doesn't usually go up to 250. It's usually between 50 and 100. But that's where they're just going to live. And there's been a lot of studies of intensifying with, you name it. In this case, the thought was doravirine. It doesn't change a thing, because all the antiretroviral therapy does that we have it available to us now is stop de novo replication. That is, a virus going from one cell and then infecting a new cell. And that doesn't happen when your therapy is effective. So this is not going to, that approach is not going to change the reservoir that's spitting out, because the virus goes out, but it doesn't infect a neighboring cell because the antiretroviral therapy is protecting that neighboring cell. So I think we just stay the course. I get personally concerned when the viral load does go above 100, because I don't usually see that very much in this setting. If they have a concomitant illness that stimulates their immune system, then you get a transient increase in viremia. You can even get that after a vaccine. But assuming it's between 50 and, let's say, 120, I don't think I would do much except move on.
No, I agree. The only thing I was going to say is I was actually going to select F, because, yes, I would not change the regimen, but you're going to have to spend a lot of time talking to this individual, and that's going to be something else that you're going to have to do. This person, frequently, this patients require you to assure them, to explain to them what is happening. And at least my experience with a few of them is that, you know, you frequently say, well, okay, fine, you know, you were 230 yesterday. Last time we saw you, we'll go ahead and get a repeat today, a viral load, and get a genotype, you know, just to be, and then you do that, and whenever I order a genotype, then the viral load becomes less than 50. I don't know what happens.
Something happens. I mean, the fact that it's never undetectable worries me a little bit, that this is persistently elevated, and I showed that data from the military cohort about higher rates of potentially of non-AIDS events. One thing I always check for, especially on dolutegravir, is the person taking any magnesium or calcium supplements or zinc, any positive cations at the same time they take their meds, because that can reduce the absorption. And I've had that, fix that, and they got undetectable. Yep. So I think you need to check about that. And then the other issue that comes up, what about their partners? Are they undetectable? Are they? And I think for most of the studies, undetectable was less than 200. So I think we're okay there. But I always make sure about drug interactions, but sometimes, you know, despite the counseling, people just want to try something different and see if they can suppress.
Great. So I have an approach similar to what has been outlined. What I do is essentially I assess adherence. I'll call the pharmacy, make sure that they're picking up their meds. I'll consider drug interactions. I think the point that was just made about multivalent cations is a really important one. Dietary calcium is okay, but exogenous calcium, you get much more of that multivalent cation when you take it as a supplement. That's what interferes with the integrase inhibitor absorption. Sometimes intercurrent illness, but that should be transient. It shouldn't be this kind of sustained, persistent viremia. I would say malabsorption. We often invoke it, but it's rarely the cause of this. And really unusual circumstances, I'll try to figure out a research lab that can do resistance testing and drug levels, but I would say this is what I almost never do that. If at the end of the day I cannot find any other cause, then I do think what has been said is the case that this may be due to release of virions from the reservoir rather than ongoing replication. And this was suggested by a study that John Mellors and others published a few years ago, looking at 8 such individuals who had long-term ART, had low-level viremia. They called it essentially non-suppressible viremia. They had viral loads that you can see there that were usually above 200, below 200, as you said, and had a median nadir that was fairly low, around 200. There was no evidence of drug resistance. They actually checked drug levels, and they were in the therapeutic range. But what they did, and I thought this was the novel part, is they looked at the integration site, and I'm going to show you an illustration in a second, but when they looked at the integration sites, the RNA was identical. That is, the integration sites there was not an evolution of integration sites, and when you see the picture on the next slide, it will be a little clearer. But that suggests that these viruses that are in the plasma are clonal. They're coming from an infected clone, and that they're just spitting out that virus, as Dr. Sachs said, but not evolving resistance. And there was no resistance that evolved over time. So the implication is that changing or intensifying ART wouldn't be effective. So this is, I think, the picture that shows it. If you have viral replication, then what happens is your virus integrates itself into different parts of the genome, and then you'll get evolution of those integration sites. That's if there's productive cycles of replication, but what they found was not that. They found the same integration site, and that indicates that there's essentially just a clone that's spitting out virus. Now, this is a small study, and there will be a variety of different instances, so as Dr. Del Rio said, you have to go through talking to the patient, making sure there's not something else. But I think in some instances, this is going to be the answer. I'm going to try to do one more ARV case, and then I'd like to do one non-ARV case, and then if there's time, we'll do a bonus case, but there may not be. So one more ARV case, and then one, I would say, hot topic that's in the news. So let's do one more ARV case. So this is a 34-year-old man who has sex with men who is getting TDF-FTC for PrEP. You're going to hear more about PrEP this afternoon. He intermittently misses doses, and he presents with fever and a sore throat, and unfortunately his HIV RNA is a million. It had been negative before, and his antigen antibody is positive, so he's acquired HIV. So you're going to send a genotype, but while you're waiting for that genotype, what regimen would you start? Would you start TAF-FTC bictegravir? Would you use a boosted PI, boosted darunavir plus TDF-FTC? He's on TDF-FTC, would you use boosted darunavir plus dolutegravir, or would you use a multi-drug regimen, TAF-FTC, boosted darunavir, and dolutegravir? Let's see what you all think. Dr. Kerr, I understand there's a successor to ChatGPT. There's some new one that I can't even remember so we'll see if they can have a better music selection. Okay, so person acquiring HIV on TDF-FTC, it looks like 3/4 of you would be okay with TAF-FTC bictegravir. Some of you want a multi-drug, 3-class regimen. So what does our panel think? And you can always, we have Dr. Scott, had Dr. Scott in the audience, but what do you all think?
Go ahead. I just talked, so I'm going to be quiet. But
I think you want to know, when you said he misses doses, exactly what does it mean, and what is he missing? Did he get infected with decent levels of drugs, or he did not? Most of those individuals, when they get infected like this, don't have resistance to to the FTC, and I feel therefore, comfortable with what the panel, what the audience is suggesting of going with bictegravir TAF FTC. I worry that his viral load is really, really high, and you obviously want to get a genotype on him, but I think putting him on a multi-drug regimen will make him even miss more doses at this point in time.
I think our hesitancy to answer is because of what everybody just said. We worry about this kind of patient, but we don't know the exact reason why he failed and got infected. The data that are available would suggest that TAF, FTC, and bictegravir would do fine, at least initially. And you have some time, because you're going to get him initially suppressed on that regimen anyway, to see what your drug resistance tests show. And you can modify, in a few days if you need to. It doesn't take that long to get them back anymore. But I think that what everybody's a little hesitant about is that viral load of 1 million copies. And do we need to do something more aggressive in the setting of such a high viral load? But
So thinking back to the biology again, this guy became infected probably at a time when either his TDF-FTC levels were non-existent or they were low level. So the concern is, if they were low level, could that replication in the face of low-level resistance induce low-level replication induce resistance? It's possible. We don't see that much resistance in people that get infected, and if you do, maybe it's a FTC or 184V, and that, as we've heard already, that doesn't seem to tremendously affect the effectiveness of the regimens, and you're going to know, as Connie said, very quickly. So I think any of these could work, but I go back to Carlos's point that the person isn't a great pill taker, so I don't want to necessarily give them a boosted agent simply because it might be less tolerable, and I'd go to something simple, and I'd go with A with the rest of the crowd.
Yeah, the only other thing, though, that I would say is to take a really careful history of, like, sometimes when people start having symptoms, they start taking their pills. And has he been taking it every day now for the last 2 weeks, or not? So that would be important, but I agree that it's rare to see resistance in seroconversion.
Yeah, these are all good points, and I deliberately kind of stressed the system in terms of giving a high viral load. It turned out that he had not been taking the drug, but those are all the key questions. As has been said, drug resistance in people taking oral PrEP is fairly uncommon. Sometimes it'll occur if someone has unrecognized acute HIV. That's becoming a little less common, as we often will be checking RNAs in people we're starting PrEP on if they have had recent exposures, or in people who have intermittent adherence. The most common resistance mutation, as was said, is M184V, and it's somewhat uncommon to have K65R. One thing that this case does not illustrate, but I want to just briefly mention, I won't go through this in detail because you are going to hear much more about this later today, is if you have someone who's now getting injectable cabotegravir, most of the time that prevents HIV, but there are some instances where there have been breakthroughs. You'll hear more about it, and when there is breakthrough, there have been reports of integrase resistance occurring, and I won't belabor that here because of time, but keep an eye on that for this afternoon. So the IAS-USA essentially endorsed these as the main options for people who are acquiring HIV on oral tenofovir-based PrEP, bictegravir FTC TAF, or dolutegravir plus tenofovir XTC. If you have someone who has had cabotegravir, though, that's when you're going to want to reach for that protease inhibitor and then adjust your regimen once your genotype comes back. So there is going to be time for questions, but I'm going to round this out with kind of a pair of cases that are not ARV related, but I think are important. We saw a number of these in the last few years. So this is a 40-year-old man. I'm going to give you the diagnosis here. It's what to do about it. So 40-year-old man with well-controlled HIV. He's on dolutegravir 3TC. He's coming with abdominal cramping and diarrhea, severe diarrhea, one to three bowel movements every hour. He's got some chills. His temperature is 100.7. He's traveled to Cape Cod. He's been at cookouts. He has 3 new male sexual partners with oral anal stimulation. You do a stool culture, and he has Shigella, okay? And he has Shigella sonnei. And so would you treat this patient? Let's see what you think. A man with Shigella Would you treat? Yes, no, only if he doesn't improve. How many people have seen this recently? Okay, so 60% yes, 35% no, or sorry, only if he does improve, 35% and no, 8%. I'm going to present a companion case in a moment, but let's see briefly what our panel thinks, and I'm going to give you another scenario with the same diagnosis in a second, but would you treat? Or if you wouldn't treat, what information would help you? How about that?
You know, he has a suppressed viral load. You didn't give us a CD4 count. At least I don't recall seeing a CD4 count.
Yeah, let's assume it's high. Yeah, that's a
But,
good point.
you know,
I didn't put that.
But this
under-
is somebody who theoretically is not immunosuppressed, and therefore somebody that you may not necessarily treat because he's not immunosuppressed. And again, the treatment gets very complicated, and you're probably going to talk about this later because as we see a lot of quinolone use in this kind of situations, frequently those patients have Shigellas, which have inducible quinolone genes, and therefore you need to really think what you're going to treat this person with, and you're talking many times about, you know, intravenous therapy and putting him in the hospital. If he's not sick enough for that, you may want to observe him and not treat him. So I want to get a little more information what he looks like, but if he just has abdominal pain and temperature, I may wait before actually treating him.
Yeah, I
What-
mean, go ahead.
Go ahead.
I mean, these cases too of multiply drug-resistant Shigella, we just had one, and that information doesn't come back in any kind of meaningful time because we're diagnosing these by PCR and then reflexing to culture. So it really needs to be based on the clinical appearance. Are they dehydrated, and you know how they're doing? But empiric treatment is not so easy anymore.
Not so easy anymore, yeah.
Right.
Yeah,
that's-
you're going to put him in the hospital
Yeah.
then because he's sick, then you're going to start him on carbapenem or something else.
What type of mayonnaise was it? I think that might matter. Just curious.
So these used to be simpler, okay? Life used to be simpler. But these, most of the time in the past, we would treat Shigella, but things have gotten complicated. So let me do one more case, and then I'll summarize where we are with Shigella, and we're not in a totally clear place. So this person did have resistance testing. We then and even now goes, default to culture. So he has a Shigella that's ampicillin resistant. They don't give an interpretation for azithro, but it's greater than 256. It won't work. Cipro is resistant, and trimethoprim sulfa is resistant. What I didn't show you here is he turned out to have ceftriaxone susceptible, and we were able to get cefixime. But by the time this all came back, he was better. He had actually resolved the Shigella. So let me present one other case, and then I'll summarize where we are with Shigella. Again, not a very clear place. So this now is a person on PrEP with diarrhea, 4 days of watery diarrhea. He has no blood in his stools. He's got no fever. He's got no chills. He's less sick. And he, too, has Shigella. And this time you do have resistance testing back. And maybe just in the interest of time, I will, well, let's see what you all think. But I'll stress here that he has a no interpretation for a Cipro. For those of you who have seen Shigella, has this come back where they give kind of an intermediate level? It's hard to see. Maybe we'll. So this person has a resistant to ampicillin Shigella, a susceptible to trimethoprim, and he has this no interpretation because he's got an intermediate MIC for Cipro.
Well, and again, what that means, there's no CLSI recommendations here. Basically, in CLSI-based says sensitive or resistance based on clinical data. So there's no data to support, so you just have to go with the MIC and say, is this MIC going to be sufficient? And that's what makes it complicated. But you don't have CLSI data, and that's what the problem is.
Okay. So with that in your minds, would you give this person Cipro? Would you give him trimethoprim sulfa? Would you not treat, or would you admit him or find a way to give him IV ceftriaxone? Okay. No, yeah. So, This is, I think, the point that I wanted to really drive home. So just a few weeks ago, the CDC put out this health advisory. What you're looking at in the graphic is the last few years. And over the last few years, there's been a really rapid rise. It's not the majority of Shigella, but 5% of Shigella are now what they call XDR, extensively drug resistant, which means they're resistant to all our available drugs, azithro, ampicillin, Cipro, ceftriaxone, and trimethoprim sulfate. This is mostly seen in MSM, people experiencing homelessness, international travelers, and people with HIV. The CDC has no current treatment recommendations. They say that explicitly. In the UK, where they've also seen this, they use a extended spectrum penicillin called pivmesalanum and fosfomycin. So they've used that in the UK, but we don't have that beta-lactam here. And in very, very, very sick people, they've used IV carbapenem and colistin if they're hospitalized. So this is the extreme. This is XDR Shigella, but I will say even more than that, I've seen a number of these other cases of Shigella that test susceptible to Cipro, but with this intermediate MIC of 0.12. The CDC put out an advisory about this about 5 years ago. But these intermediate Cipro Shigellas do harbor resistance genes, and it's essentially unclear whether Cipro will work. And what the CDC essentially has come down to is if you have someone who's ill, who's immunosuppressed, or if you're in an outbreak situation, that's where you should be thinking. And again, this is different than it used to be before this resistance became an issue. I think if I were to treat, I would have used trimethoprim sulfate like I think half of you would have. So I'm going to wrap it up there. I want to thank you all, thank our panelists, first of all, for their outstanding discussion. And I want to thank you all for your attention. I'm going to look to our moderator to see where we are. Oh, terrific. Okay. Thank you very much. So, so let's start with the first question. What causes elite controllers to lose control? And what inflammatory markers go up first? Have any of you had an elite controller that you want to reflect on? So why do some people lose elite control, and is there an inflammatory marker that really presages that? I think we probably don't know fully the answer as to why this happens. I will say that in some instances...
I was going to say immune senescence. We just get old and eventually we lose control to a lot of things.
So there are some data. Actually, Matthias Lichterfeld at Mass General and Brigham did a study where he looked at elite controllers and he looked at their transcriptional profiles. And he found that some people who are elite controllers have a very quiescent transcriptional profile, and those are the ones who had normal CRPs, very low CRPs. He found another group of elite controllers that had a more active gene profile, and those CRPs were high, and their CD4 to CD8 ratios were low, as Dr. Sachs said. Numbers are small, so not enough to make a firm conclusion, but we haven't, we don't have a guideline that says to check a CRP. But I think probably some of it is immune escape, some of it is evolution of escape to CD8 cells, and some of it is just things we don't yet know. So, let me switch up and go beyond elite control. Can someone tell me about how much time I have? Because these are great questions. I want to get to as many as I can. Okay. A lot on elite control. Can I ask the panel what they do? If you have someone who you're going to give cabotegravir rilpivirine to, say they really are adherence challenged and they want an injectable, but they have a history of K103N, and let's say you do a proviral genotype and they don't have any rilpivirine resistance. If you're going to give that person cabotegravir rilpivirine, would you give it every 1 month, every 2 months? How would you approach that decision? Obviously, it's approved for every 2 months, but it first came into common usage as every 1 month. Any thoughts on frequency of dosing of cabotegravir rilpivirine?
I mean, this is judgment. This is just using your brain, knowing what you know about the drug levels, and the concern that towards the end of the second month, that the levels in certain people start to drop. And so you're dealing with a little bit of a weakness in the regimen, at least theoretically. So I would lean towards monthly, although that's real expensive. It's a lot more difficult to do. I'd really try to find something else. But in the case of harm reduction, if you've got somebody who can't take a pill, any kind of oral regimen, And we don't have yet a lenacapavir option without pills that we could use. I think you just negotiate, but I'm really not comfortable with using it in that setting personally.
Any other
You know,
comments?
again, we have no data, right? And with the presence of an M184, as you said before, you even feel uncomfortable going there. But, you know, if that's what's going to try to suppress your patient, try it. But if I did that, I would like to go to monthly, even though, you know, patient may not show up every 4 weeks.
Yeah, in the Ward 86 experience that I shared the poster from, they did it every 4 weeks, I think out of abundance of caution, although, you know, we have to remember that every 8-week dose is more drug, just lasts longer. So I don't know if we're treating ourselves there, but I think sometimes just to have really good follow-up, and then once they're suppressed, you could switch to every 8 weeks.
Terrific. I think what I'm going to do is we'll wind down for now. I'm going to stay up here, and during the break, we'll happy to take other questions. But thank you again for great contributions, and thank our panel, and we'll look forward to talking at lunch.